ऑडियो भी बोल रहा हूँ, ठीक है। अभी ऑडियो वीडियो ऑन होगी, ठीक है। आप अपने माइक से ठीक है, जैसे स्टार्ट बोलेंगे तो अभी हमारे पुराना साहब से जरा ऊपर है, चेक कर लो तो आवाज आ रही है। माइक अपने बोले तो आवाज आ रही है, पुराना ठीक है, चेक करें।
Assalamu alaikum, sir. Sir, Malik Imran sir, can you hear us?
Assalamu alaikum.
Okay, sir, yes, sir, we can hear you.
Okay,
Okay, thank you, sir.
इसको थोड़ा
Respected chairperson of the session, Dr. Maipala Palita, WHO Pakistan. Respected co-chair Dr. Basir Achitri, Director Nutrition, Ministry of National Health Services, Regulation and Coordination. Distinguished guests, ladies and gentlemen, good afternoon. I'm very grateful to all of you for giving us precious time to make this session successful. I'm also very thankful to the Health Services Academy for giving us the opportunity to share our experience and create a strong networking. I'm especially thankful to Dr. Maipala Palita, WHO Pakistan, sparing his valuable time for this session. Thank you, Dr. Let me introduce myself first. My name is Shawla Goman, and I'm the Secretary General of well-known organization of Pakistan, I mean Pakistan National Heart Association, commonly known as PANAH. I shall be the moderator of this session, jointly organized by PANAH, WHO, and Ministry of National Health Services Regulation and Coordination. PANAH was established at EFIC and IIT under the leadership of world-renowned cardiologist General Zulfikar Ali Khan, with the presidential order, that time General Muhammad Ziaul Haq, for the prevention of public advocacy, for prevention of heart diseases, and training people in cardiopulmonary resuscitation. Since that, PANAH is working to spread awareness and educate the people for reducing of these diseases through seminars, walks, workshops, medical camps at far-flung area of Pakistan, conducting and disseminating research studies and implementation various projects for reduction of risk of factor for NCD. We have strong relation with the media. We also use print, electronic, and social media for public advocacy. We also working closely with law and policy makers to help them devise policies to control non-communicable diseases. PANAH is aggressively working against tobacco and sugar-sweetened beverage to save especially our youth, which are among the major risk factors of non-communicable diseases. This association had also put in a good share in helping people who suffered in the national disaster that struck the nation in the past. PANAH also helping poor patients get expensive cardiac investigations, angioplasty, stents, and cardiac surgery. Since its inception, the President of Pakistan, starting from General Ziaul Haq today, has the patron chief of this association, Dr. Arif Rahman Ali, President of Islamic Republic of Pakistan, is PNA's currently patron chief. Before starting the session, I would request for recitation of Holy Quran.
والضحى والليل إذا سجى ما ودعك ربك وما قلى وللآخرة خير لك من الأولى ولسوف يعطيك ربك فترضى ألم يجدك يتيما فآوى ووجدك ضالا فهدى ووجدك عائلا فأغنى فأما اليتيم فلا تقهر وأما السائل فلا تنهر وأما بنعمة
Jazakallah. Next, I would request Dr. Basir Khan Ajay, Director of Nutrition, Ministry of Health Services, Evaluation and Coordination, co-chair of the session, for welcome address and opening remarks. Sir.
WR Pakistan, Malik Saab, previous house. It's a great pleasure that we are having you, sir. We usually collaborate with organizations like PANA, like any organization in Pakistan, which try to work in the domain of health, especially prevention of certain diseases. And it is a very unique opportunity for us to collaborate with certain organization who has great and valued experience of the past, like PANA, who are working in Pakistan. And sir, you are aware that the NCD is the next generation, or you can say the big issue of Pakistan in the coming days. The majority of the intervention which required to address or to tackle non-communicable disease is one way or another way prevention, to talk about prevention and to create advocacy among the masses. And I have personal experience with the PANA, working with PANA, that they are great educators. They educate on so many occasions, or in each life sphere, they are doing this job. And we, the Ministry of National Health Services and Regulation, since sensing that they are valuable partners, so we are working with them, and on one call, we usually collaborate with them. I was just speaking, sir, in another session to the, especially the young fellows who have just entered into the domain of public health, or if they are researcher to one way or another way, that Pakistan has shown wonderful in the domain or field of public health for the last 2 or 3 years, especially I'm talking about the COVID response, because if you just calculate the number of patients who admitted in hospital were less as compared to the number who were infected but they were cured. So the cured people I think the role of the public health professions are very great and at grassroots level. And of course, that would not be possible without the support of WHO. I am saying you, sir, right nowadays you are very active on social media as well. So maybe somebody will say that is a very rich man, so let's kidnap him. So be careful, sir. You are on each and every platform, and your services have been recognized by Ministry of Health. And the day before yesterday, when the Minister staff spoke about the WHO role and especially UN agencies, the response to Pakistan disease is of high value, and we expect the same support in the same field to focus on. I'm grateful to the Kuman Saab as well that Kuman Saab usually do not miss an opportunity to send or to speak in any such huge conferences and to bring this agenda on the table to recall the attention or especially to give certain importance to the issue that how these sugary drinks, how these you can say the excessive use of salt or beverages or even the trans fatty acid is a very huge problem in Pakistan, which Fazal Saab and the WHO team has worked a lot on that. And since both are side by side and very important, we need to incorporate both of them and to make a one response to involve so many people. So thank you, Kuman Saab, and thank you, Jod, for your giving us time for this very important session. Thank you, Kuman Saab. Thank you.
Sir, I'm grateful to you, sir. Thank you very much for so sweet words for Mana and others. Next, I will request Professor Dr. Abdul Hamid Siddiqui, consultant cardiologist and physician, classified medical specialist, professor of cardiology, professor of medicine. I request, sir, you have.
The permission of the chair, I'll start my presentation. It's always pleasing and really heartening to be part of the gathering, which is talking about how we can prevent the diseases, that is the non-communicable diseases, which is taking a toll of our younger population. Since I'm a cardiologist and an intervention cardiologist, and I'm daily seeing the effects of NCDs as part of tertiary care hospital. And now we used to see cases of heart attack in their 40s to 50s, and now we are seeing it in their 30s. So, and some of these patients do not have any risk factors, like risk factors of diabetes, hypertension. I think it's high time to focus on prevention. As we are a developing country, we have to spend a lot of money on the tertiary side. So it is really important to focus on the NCDs at the primary level. So
Yeah.
So basically, today's session is regarding the dietary factors and the NCDs. Next slide. So this is the busy emergency and OPD of National Institute of Heart Disease, and you can see it is jam-packed. So the globally disease burden, as you already know, that is almost touching the NCDs are estimated to account for over 50% of all that, and the main chunk is borne by the cardiovascular disease, right? Almost almost third of all of these. So globally, the sad part is that most of these deaths because of NCDs are in developing world, that is in our part of the world, and it almost accounted for 82% of these deaths in our part of the world. And out of these, 50% deaths are because of the cardiovascular diseases. As far as the projection is concerned, by 2030, these NCD is going to top the list of all the causes as far as the death is concerned globally. Now, next slide. As far as the Pakistan is concerned, it is facing the burden of NCDs, and it accounts for only 49% of all the diseases. As for the proportion of different NCDs, the cardiovascular diseases are 18%, diabetes prevalence is around 26.3%, and chronic respiratory disease they account for 12.1%. So, as far as the disease mortality is concerned in Pakistan, still they almost mimic the figures of the international world. That is the cardiovascular disease, they account for nearly 48% of the death, cancer 21%, and chronic respiratory disease 12%. Diabetes is responsible around 3.5% of the death. In Pakistan, the NCDs are estimated to account for nearly 50% of all the deaths. Next slide. Well, regarding the risk of premature death because of NCDs is concerned, although the internationally the WHO is focusing by 2025 that it has to be brought down below 20%, but the projected trends are still very high. So we really need to work on this at the primary level to bring it down to less than 20%. Well, just recapitulation of some of the risk factors of the NCDs. The main focus, as I said, which is responsible for nearly half of the NCDs is cardiovascular disease, and some of the risk factors they are modifiable and the others are not modifiable. So our focus would be on the factors which we can modify at the primary level. No, but the sad story is that the factors which can be modified, like tobacco, which accounts for nearly 6 million deaths every year. And out of these, the 600,000 deaths are in those who are second-hand smokers. Similarly, around 3.2 million deaths can be attributed to insufficient physical activity, and 1.7 million is related to decreased intake of food and healthy diet. There are 2.3 million deaths because of illegal. So, not only the disease burden is high in this part of the world, but also we are lacking the vigor and resolve to address these NCDs. So what are the reasons for this? Well, there are certain genetic predispositions. The tobacco is easily available here, the unhealthy diets, urbanization, lack of physical activity, and importantly is also the lack of awareness because of low literacy rate. So all these factors, they contribute to our lack of initiative to address these issues, that is NCDs at the primary level. So really we need to change our attitude, we need to change our habits. Next. So we really need to focus on the root cause. Next. Well, I'm not going to give you here any sort of details of any primary prevention strategies, but I just give a passing reference to some of healthy activities or healthy attitude that we can adopt. So we need to focus on regular checkups. Next, please. We need to know our numbers regarding the main risk factors, that is hyperlipidemia, diabetes, hypertension, obesity, so on and so forth. Next, please. And we need to focus at the risk factor level so that we can prevent the patient going into the development of the disease, and finally, rather spending our energies on the treatment of these diseases at the tertiary level, which is very costly. Well, as far as the national figures are concerned, 45% of adult population never get their blood pressure checked, and 78% of their population never get their blood glucose level checked. So this is what the state of affairs is. We need to improve upon that. And 90% of adult population never get their liver profile checked. Only 50% of the hypertensive are on the medications, and only 10% of diabetic patients have their blood glucose levels in the desired level. 60% of the Pakistani population either fall into the category of physically inactive or do only light physical activity. So the important thing is we need to improve on that. Next, please. So just a few points that how we can adopt simple strategy to focus these factors. So all individuals who are more than 40 years of age should undergo some clinical evaluation as far as the cardiovascular disease is concerned, which is the main part of the NCD. And those who have family history, we have to do that early. Next, please. We have to focus on the patient who have some borderline failures. We have to focus on the healthy lifestyle promotion activities. And these should be done at the earlier level. Main focus at the primary care level, that is at the level of the GPs, primary care physician, focus on these risk factors so that we can decrease the burden of the disease. Next, please. There are a number of slides because of the paucity of the time I would give them. So as far as the tobacco is concerned, 35 million population use tobacco in different forms, and in certain ethnicities, the figure goes to as high as 75%. The average age of initiation of tobacco smoking is around 20 years age, which is quite a younger age, so we need to focus on our youth and in the educational institution. Important thing is to stop smoking if the individual with. And the benefit of smoking are only be gathered when you stop smoking. Even if you smoke 1 or 2 cigarettes, you do not get any benefit, or you not reach the zero level that you want to attain. Next, please. Next, please. The important thing is to, not only those who are active smokers, but those who are not active smokers. Even the passive smoker can is detrimental to health. I think as far as the smoking campaign is concerned, Naval Roman is the main spearhead or front runner in this regard. He's after the tobacco industry, and I think skip this part. He's trying to increase the taxation on the tobacco sale and increase the prices of the cigarettes so that they are not easily available. And I hope his efforts will bear fruit someday. Next slide, please. Next, please. Now, today's, I think the topic is basically the food choices, and there is going to be a talk regarding trans fatty acid. So I'll just give a passing reference just as an remarks. Next slide, please. We are all aware of the food that we eat, particularly in outdoor. They're all filled with trans fatty acids, which are detrimental for our health, as well as the, with particular reference to the cardiovascular diseases. They contribute a lot towards the development of cardiovascular diseases. Next, please. So we need to know healthy eating, the Mediterranean diet, which is the vegetable, fruits, olives. Next, please. So what are the recommendations regarding there might be different efforts at the governmental level, at the primary care physician level, at the institutional level. So I think we need to use all the resources to bring down the burden of the disease in general. Next slide, please. So we need to focus, we need to encourage the physical activity, as I already mentioned. I think less than half of our population is adopting the required physical activity that is required to improve the health of the individual and the nation and of the population in general. Next, please. Well, at least some sort of physical activity is better than nothing activity. Next, please. Well, stress is not the causative agent as far as the cardiovascular disease are concerned, but they do a lot in triggering the events which lead to development of events which culminate in disability with particular reference to the cardiovascular diseases. They are one of the important triggers in the heart attack. Next, please. We have to focus on a community level regarding our public education, and we need to develop our campaign at different levels for physical activity, mass media campaign, and so forth, and so on and so forth. I'll just skip some of these slides. Next, please. Next, please. Next. So we need to modify our behavior as far as the physical activity is concerned. Next. And we need to promote healthy activity. Now, I'll just give a next please. For the information of the audience, highlight here that from the public health point of view, the Ministry of Health Center of Excellence is being built in the as part of the NIHD, National Institute of Heart Disease. Next slide. Now, this is the NAP, which will be part of the National Institute of Heart Disease, and this is the Center of Excellence Prevention of Cardiovascular Research and Development. And now, this institute is in the inception year. The location has been earmarked in the vicinity of the NIHD, and the PC1 is under the process of approval. Next, please. Now, I'll just summarize what is the objective of this NAP card. The basic objective will be to focus on the preventive cardiovascular research, specific reference to NCDs. And it would be a federal institute, and the main emphasis would be to integrate all the research as far as the NCDs is concerned, to focus it at one central point. It will be integrating, next slide, it will be integrated with all the provinces, and so that some cohesion and coherence be achieved in different provinces. Whatever research activity is being generated related to the NCDs, now that will be integrated in this center, so that we can have a comprehensive plan as far as the primary prevention of NCDs are concerned as a national policy. So as a part of the inception year, this NAP card has done a recent survey on prevalence of oil and ghee consumption in general population. This was a cross-sectional survey. Next slide, please. I'll just go through some of the slides, not all of them. Next, please. The focus was basically on the trans fatty acids and the different diet. Next, please. The objective was to determine the frequency of daily oil, butter, and ghee consumption in the general population. Next, please. Next. Next, I'll just focus on the results. So the mean age of the population was 43 years. The weight of the individual was 69 kg. The mean height was 65. Next, please. 3.6 individuals were underweight, and the overweight were 33 were over, and 14.2 were obese. Next, please. So this was the main thing. Data was acquired from all provinces, but the maximum was Punjab. Next. There was still diabetes, hypertension, hyperglycemia, obesity, coronary artery disease in different proportion as depicted. Next, please. There are some patients who had cardiac intervention as well. Next. So the mean cholesterol was 163. The low density lipoproteins were 112, and the triglycerides were 183, and the blood glucose then the peak was around 108. Next. Smoking status was 0.7. Current smoker and ex-smokers were 6.9. Next, please. So, in conclusion, 39% used oil for cooking twice a day, 14.1% used ghee for cooking twice a day, and there was low usage of butter, both salted and non-salted. Next. 35.4 used curry twice daily, and 19.4 used deep frying as a mode of cooking. Next, please. 4.6% people consumed junk food daily. So, monthly mean consumption per household was around 5.5 liters, and the average family members per household was 7. Monthly mean consumption of the ghee was around 1.8 liters. Next. So the conclusion was there was higher trends toward overweight and obesity. This is basically a study, and the consumption of oil of curry is relatively high, and junk food and processed food was reported on daily basis. So the recommendation, well, I think there are going to be speakers afterwards. The recommendations are formulated later on. But anyway, the multiple stakeholders' efforts for harmonization are mandatory to reduce the use of trans fatty acids with replacement of traditional transmitted ghee. And we need a lot of communication to bring about the behavioral change. Next, please. I think I'll stop here. Thank you very much.
Thank you, Professor Dr. Abdul Aziz Isa. Thank you very much. My next speaker is Dr. Khwaja Masood Ahmad, National Coordinator, National Ministry of National Health Services Regulation and Coordination. Khwaja Sahab, please.
Bismillahirrahmanirrahim. Thank you very much, Oman sir, respected Dr. Parikh, Dr. Tasir, colleagues from different organizations and partners. This is not touched upon. Our main basically focus is the dietary risk factors, and one of them is the sugar. Apart from normal sugar utilization, there is a growing trend of using sugar-sweetened beverages during the past decade or so. So I will be discussing some of the health harms of these sugar-sweetened beverages and how they impact the health and nutrition of the people. Next, please. As Professor Saab also highlighted, overweight, obesity, and NCTs are a public health emergency in Pakistan. In 2014-15, STEP survey was carried out, which revealed that almost half of the population is obese and overweight. NNS 2018 confirmed partially these figures. Taking into account the women of reproductive age, the percentage has gone up to 38%, and almost half of these are in urban settings. We will also see the overweight and obesity in children and adolescents. So this is not only for adults. The behavior change starts very early in life, and we can see that even the children under 5 and adolescents are having more overweight and obesity. 428 billion rupees is the estimated cost of health and other hazards which they cost the economy. That's in 2011, only 5% of under 5 children were overweight and obese, and this proportion has almost doubled in the last 7 to 8 years. And if we proceed with the same ratio, 1 in 5 children under 5 would be overweight or obese by 2025. I also discussed in the previous slide that almost 38% of women of productive age are now overweight and obese, and if the same trend goes on, every second woman of reproductive age would be overweight and obese in 2025. That's as I discussed earlier, the trend is not only in children and adults, but the same trend goes on in adolescents. 1 in 5 adolescents are overweight and obese, and these are the figures of 2018. And we know that within the last couple of years, especially after COVID, the dietary habits have drastically changed negatively. People sitting at home and getting the junk food or fast food delivered to their homes. Definitely, if we carry out the same survey today, I fear that this percentage would have gone much higher. Next. Most of these figures have been shared by Professor Saab, so I will not go into details. Next. This is an important slide which I wanted to highlight. If we see in 1992, the communicable disease were causing more than 50% of deaths, while the non-communicable disease were causing less than 1/3. But if we go to 2008, the proportion has reversed, and it is to 2020. So it is very pertinent that almost 60% of the deaths today in Pakistan are due to non-communicable diseases. Next. As per International Diabetic Federation, in 2013, Pakistan was not even in the top 10 countries with the highest population suffering from diabetes. In 2017, Pakistan had the 10th highest burden, and in 2019, rapidly jumped to 4th highest burden, with almost 20 million cases of diabetes in the country. This clearly shows that how the use of sugar has increased very rapidly in the past decade or so in Pakistan, and the trend is not coming down. So we have to do something as soon as possible. Next. This slide has also been shared by Professor Saab. The proportion of mortality is almost 60%. Next. Now, how sugar sweetened beverages contribute to overweight, obesity, and non-communicable disease like diabetes? And sugar sweetened beverages are any liquids that are sweetened with various forms of added sugar, and this can be any form. I mean, it's not limited to just the white sugar, brown sugar, sweeteners, corn syrup, dextrose, fructose, everything that leads to sweetening of liquid produces sugar sweetened beverages. And they also include sodas and flavored milk and juices. Unfortunately, since a couple of years back, we thought that these fat juices are very healthy, and I mean, I myself remember that we used to recommend that don't drink these sodas or cola drinks. Instead, use these fat juices. But with the latest evidence, we know that these juices are as harmful as these cola drinks or energy drinks. They have very high calories, but limited to no nutrition value. These are some of the examples of the drinks with the level of sugar. These soda drinks have almost 7 to 8 teaspoons in 250 ml, and even the juices have the same value, even higher than these cola drinks or soda drinks. Compared to calories from solid food, these liquid calories are less satisfying, so you still feel hungry. I mean, they may quench your thirst for a little while, but they do not satisfy your hunger. and you still feel that you need to eat more. So these are calories which are taken without any benefit. And the normal food then lead to so many extra calories in consumption. The amount of sugar in one serving of many of these sugar sweetened beverages is more than the daily requirement of a person. So these empty calories, useless calories, just lead to weight gain of the person. And drinking one soda a day increases the likelihood of being weight by 27% in adults and 55% for children. These are absorbed very quickly. I mean, the moment you have these sugar sweetened beverages, there is an insulin storm, and these are absorbed very quickly and go to liver, and later on these are converted, stored in the body and converted to fats, leading to high blood pressure and inflammation. These high blood pressure and inflammation can increase the risk of diabetes, CVD, stroke, decay, and liver disease. Next. Unfortunately, whatever little evidence we have, this also indicates that these beverages are addictive. I mean, we can see around that our children who take these beverages and a pack of chips daily, they become addicted, and they have to take a pack of chips, these potato chips and sugar sweetened beverages every day. Otherwise, they would fight, they would argue with their family, and ultimately they would get what they want. So the same withdrawal effects are seen when these sugar sweetened beverages are withdrawn from the diet of these children. Next. Thank you very much.
Thank you very much, Dr. Khwaja Masousa. Thank you very much for giving such a nice vision for audience. My next is Mr. Munawar Hussain, who was the country representative for the Global Health Advocacy Incubator in Pakistan. Over to you.
Thank you very much, Musa. Respected Chair, Dr. Mahbala Paritha, and Co-Chair, Dr. Basira Chikzai, ladies and gentlemen, Assalamu alaikum. My name is Munawar Hussain, and I work as a consultant with Food Policy Program. And my presentation is in continuation to what Dr. Khwaja Masousa has actually did, and I'll be discussing some of the policy options for reduction of the consumption of sugar-sweetened beverages and the way forward. Next slide, please. Just a quick overview of what we are consuming at the moment in terms of sugar-sweetened beverages in 20. This data is from 2018 about the total consumption, and nearly 387 billion rupees our consumers are spending on carbonated beverages, 58 billion on energy drinks, and 79 billion on juices every year. And the frequency of consumption, that is the survey that has been done by Pakistan Health Research Council in 2021, shows that 17% of the population, they consume sugar-sweetened beverages on a daily basis, and half of our population consume SSBs at least once in a week. And even if we calculate separately the adolescent group, the percentage is even higher. Next slide. And while we are moving towards a solution and various recommendations, the options that we can do in Pakistan, let's look at some of the best practices in the world. One is, of course, increasing the tax of the surcharge. And even in the tax, the sugar density based tax remain to be more effective. And then the more focus and the more success is when you implement a package of healthy food policies, along with the tax for larger impact, including front of packing labelings, marketing restriction, and school food policy. Next slide, please. Why tax, in fact? The tax have been shown to decrease consumption of sugar-sweetened beverages. The tax on SSB is an important first step It might not be the all, but it's the first important step to fight obesity and obesity-related disease. And of course, WHO has published guidelines saying individuals should not consume more than 10% of the total calorie intake from the added sugar, and ideally this should be brought to a 5%. And if you look at like only a 330 ml can of this soda, as Dr. Faja has also mentioned, and it will contain 9 to 11 teaspoons of a sugar. That means you have already taken up your maximum daily requirement of sugar, and you are on risk if you're taking sugar from any other source. And SSB tax, being a policy intervention, could like reach population at large, and the universal healthy food policies are more cost effective and can reach more people as compared to the individual one-on-one strategies. Next, please. There are a couple of like take homes from some of the recent evidence that has been generated on taxes. Mexico increased the 10% tax, and they have been able to reduce consumption of sugar-sweetened beverages from 56% to 43%, classified as a medium and high SSD consumer. And in addition to the reduction in the consumption, they have also been able to raise the additional revenue of 2.6 billion. And similarly, Chile has another example, recent evidence that where the once the tax has been increased, immediately after 3 months, the price of the beverages has increased. Next slide. Next. Yeah, this is one of the another case study from South Africa, where South Africa has highest obesity rate in Sub-Saharan Africa. And prior to passage of the tax, the South Africa were among the top countries having in terms of top 10 countries in terms of consumption of sugar-sweetened beverages. And one of the issues was that the industry opposition was very strong for tax proposals, and this is the same case as we have in Pakistan as well. And in South African partner build a public awareness of and support for tax by linking sugar-sweetened beverages and non-communicable disease using evidence from Mexico. And building on like evidence from Mexico, the approach was to demonstrate public support using petitions and public opinion polls, and position the tax as a decision between the public health and the corporate interest, and show the cost of inaction to pressure policymakers or to engage policymakers. The health promotion levy was introduced in April 2018. Sugar-sweetened beverages are taxed with 2.1 cents per gram of the sugar in the beverage that contain over 4 grams of the sugar. And you know, the amazing result that they have achieved was almost 1/3 reduction in sugar-sweetened beverages, and the grammage of the sugar that also reduced to 57%, like more than a half. Next slide, please. There are a few more examples, modeling studies from various countries, and like India, Australia, UK, Ireland, where when the tax, the increase in the tax will help in reducing the obesity, overweight, and also the non-communicable diseases. But the nutshell of this slide is the more the tax increase, higher will be the impact in terms of reduction of consumption of beverages and the NCDs. Next, please. Usually we hear from the industry that once we increase the tax, that would bring joblessness and etc. That has been one of the arguments that they use. But the studies that been done in Mexico and South Africa, they also generated the evidence that this argument is not valid. Rather, there is of course a transformation of the economy. If the unhealthy beverages consumption has reduced, the healthy options has increased, the water consumption has increased. So it's a transformation of the economy if there is no joblessness or there is no shrink in the economy. So if industry raises this sort of argument, that argument is not valid. Next slide, please. And these are various countries across the globe where this tax on sugar-sweetened beverages has been like applied, and almost these are where there's a WHO guideline as well for tax increase in these countries. Most of them are closer to those guidelines. Next slide, please. Once we look at Pakistan, have very low taxes at the moment, not only in comparison to the region, but also to the many other countries. Like India has 40% tax, 28% GST, and 12% goods and beverages tax. Maldives, if you buy a 1 liter, you have to pay $2.18 dollars as a levy, which is equivalent to 335 rupees of per liter. South Africa, Bahrain, Qatar has 100% excise tax on energy drink and 50% on irritated water. Pakistan has 13% FD only on irritated water, like the carbonated beverages, and 0% FD on the juices and syrups. And that's a major blow that we are very low in the taxes, and that's the reason over the last 1 year the increase the consumption and of beverages grown to 14%. Next slide, please. Another important area is restrict ultra processed food marketing. Next slide. And if you look at the food marketing is everywhere, either even in terms of the in the name of corporate social responsibility, or like you can see the celebrities engagement and all the tactics that has been done by the industry to market unhealthy foods and beverages. Next, please. And these advertising strategies, the advertisement is just of the iceberg. In addition, the product placement, charitable sponsorship, and government lobbying is also a part of their tactics that they're using to promote their unhealthy products. Next is one case study from Chile, where in 2014, 52% of Chilean adults and 34% of Chilean children under 6 were overweight and obese. And Chile also had the highest per capita consumption of sugar drinks in the world. And in 2016, government enacted food advertising and labeling law, and products that do not meet specific nutritional criteria are prohibited from being marketed to children under 14 years of the age, and the ads cannot be aired on like the child-directed media. So that was a good step by the government, and the result were phenomenal. And the breakfast cereal packages using child-directed marketing strategies dropped 36% to 21%. TV ads promoting unhealthy foods and drinks decreased from 42% to 15%, and even the preschool and adolescent exposure to TV advertisement for junk food decreased from 44 to 58% respectively. Next, please. Now, some of the evidence related to healthy food, the school food policies. Next, evidence-based standard. The evidence shows that the evidence-based standard for healthy school meals can improve child diet within school and outside of the school as well. The learning that children have in the school, that also goes with them out of school as well when they go to their houses. A meta-analysis of 91 studies examining the impact of different school food environment policies around the world found that setting standards for the healthier school meals increased food intake while reducing fat and sodium consumption across child's entire diet, and not just the food consumed at school. But on the other side, if you look at the heavy promotion of unhealthy foods and the beverages on school grounds, reinforces the unhealthy choices and undermine the messages to students about healthy eating habits. Next, please. Looking at the Pakistan's context, Pakistan imposed the restriction on availability of the carbonated sugar-sweetened beverages and the energy drinks at schools through provincial food authorities, and including all sugar-sweetened beverages. Punjab Food Authority did a fantastic work, and they developed a traffic light system of having various categories of red, green, and blue categories of the food. But these regulations are good start, but these need to be further strengthened because there are still some foods which are being included in the green category, which should be actually in the red category. Summary of if I look at the summary, then of the recommendation, we need to increase tax, Government of Pakistan, on sugar-sweetened beverages. And I also would like to mention that the survey to gauge public support that was done in 2021 by a national survey by Patna Health Research Council, they also revealed that 85% supporting people support increasing tax to fund public health and nutrition program. So that means if we earmark that revenue for strengthening health and nutrition, that also reflect the next slide, please. Yeah, that reflects the people's opinion as well, and there is a strong public support for increasing taxes. And second recommendation would be to regulate marketing, particularly of the ultra processed food, sugar-sweetened beverages, including removal of the health claims on unhealthy foods and child-directed elements. And then required mandatory evidence-based front-of-packing labeling on all the packed food and the beverages, and a package of policy like chili would be most ideal to reduce the burden of obesity and non-communicable disease. Just last slide from my side related to some proposed way forward for sugar-sweetened beverages tax. Next slide. We need to, we all know that the health contribution bill, health levy bill or health contribution bill was passed by cabinet in 2018, and that need to be expedited, and that's an important work, and that would not only add a surcharge to tobacco but also to the beverages. And then avail window to get federal excise duty increase before next finance bill. Even like, you know, the problem is so big, but we should not wait for another year to the change should take place on the next finance bill. Rather, we should look into the window that is available prior to that even finance bill, and then conduct sugar-sweetened tax mapping to identify gap opportunities and develop and submit an early proposal for equity. And thanks to Nutrition Wing under the leadership of Dr. Basir and Dr. Khwaja Saab, that they have already like agreed to, and they're working on an early proposal for increasing equity, and that will be submitted from Ministry to Ministry of Finance. So I think that would help in availing any opportunity that exists before even the finance bill. And then we of course need to continue high-level advocacy campaign for tax increase by including particularly Ministry of Finance, FDR, etc., and the decision maker in the cabinet as well. Thank you so much. Thank you.
Thank you very much for such a nice presentation. My next speaker is Dr. Noreen Al-Dishtar, NPO Nutrition, Food Safety and Environment Health, WHO. Over to Dr. Noreen.
An overview around transfer cases in Pakistan. And next slide, please. Yeah, this is these pictures they are showing an effort like how advocacy has been done and assessment has been done around transfer cases in Pakistan since 2019 from WHO, Heart5, Ministry of Health, and other partners. Yes. So transfer acids, they are naturally occurring as well as they are artificially or industrially produced. And the naturally occurring, they are mostly in dairy and meat. And artificially occurring or industrially produced, they are the one, those are more harmful. And they have no nutritional value, health benefits. And if you can go to the next slide, please. So these are some of the features of industrially produced trans fatty acids that are profitable to food industry, and the reasons are they are less expensive, high smoking temperature, easier to use in baked and deep fried products, withstand repeated heating, like they are making samosas again and again, satisfied at room temperature, longer shelf life, and desirable sensory characteristics. Next slide, please. So global public health impact of trans fatty acids. Enough has been said about this, but 28% increase in coronary heart diseases, 507,000 deaths in 2010 because attributable to it, as well as increase in mortality in low and middle income countries. Decrease in trans fatty acids is attributable to in high income countries, for example, Denmark, USA, Germany, where they gain benefits out of it. Next slide, please. So this is one slide which is showing the evidence that how reduction in cardiovascular diseases mortality by 22 deaths per 1 lakh population per year in Denmark due to trans-fatty policy introduction. Next. So WHO guidance, it says that limits trans-fatty acid consumption to less than 1% of energy consumption and less than 2.2 gram per day. Trans fat elimination included as a priority in WHO 13th General Program of Work. 1 out of 25 global non-communicable diseases indicators adopted at the 66th WHA in World Health Assembly in 2013. And all countries should aim to eliminate industrially produced trans fatty acids by 2023 by WHO replaced package. So, what is replace? Replace is an action package to eliminate industrially produced trans fatty acids through review of the dietary sources of industrially produced trans fat and landscape for required policy changes. And this has been done in Pakistan through WHO support. Then promote the replacement of industrially produced trans fat with healthier fat and oils. And we know that this has also been done, and WHO headquarters also provided support to gain in this context, legislate and or enact regulations to eliminate industrially produced trans fatty acids. We are moving towards it, and there are several sort of workshops around it. Also assess and monitor trans fat content in the food supply and changes in trans fat consumption in the population. Create awareness and enforce compliance with policies and regulations where we are lacking much. Can you please go forward? So these are the technologies, and this could be oil blending, then bitter esterification, and fractionation. So can we move to the next slide? Because these are very technical, the previous slide. So this is around the world where it could be done by mandatory labeling, nutrition recommendations, the awareness raising on it, legislation, as well as healthy and agricultural policies around it. Next slide. Lessons from literature says that mandatory limits are the most consistent and effective ways, leadership by government institutions, multi-stakeholder platforms, regulations, strong monitoring mechanisms, and evidence on intake. So this has been much discussed, but we can see that Pakistan is having the highest consumption of trans fatty acids after Egypt in the region. Can you please move to the next slide? So these are several sources, and this study was done by WHO through Pakistan, through Ministry of Science and Technology wing, and it was found that in the Banaswati ghee, it is reaching up to 34.4%. In margarines, it is reaching up to 34.8%, and shortenings 31.7%. So these are really rocket high, and the impact is in the form of heart attacks and several other cardiovascular factors. So these are some other figures where it is so high, and WHO says that it should be less than 1% of the energy which they give, and it is showing this. This slide is showing that it is mainly local, but we procure it from Malaysia as well and Indonesia. Can you next slide? So these are the key government stakeholders for trans fatty acid elimination in Pakistan. We have PQSCA is a wing of Ministry of Science and Technology. Then we have provincial food authorities, then Ministry of National Research Regulation, and Provincial Department of Health. These are other key stakeholders which are showing here, and Ministry of Food Security and Research and NIH and other. Then key industry and civil society actors, we could see that Kharpai is sitting with us, and there are scaling up nutrition, Pakistan NCD Alliance, and associations. Existing TFA regulations in Pakistan. This will be taken care by Professor. She will shed light on this. Can you move please to the next slide? So these are the key regulatory challenges which are ignored in Pakistan, where after decentralization there is fragmentation in different parts of Pakistan. But in 2020, by the CCI, it was agreed that Ministry of Science and Technology will be the one which will be harmonizing it across Pakistan. And then streamlining federal and provincial regulatory, then monitoring is another important factor, taking industry lobbying. Because lobbying, especially Nestle and many other, I will not take the, but this is again a very big challenge, and generating data is another, and how to do different checks. And and in replacement where you need to go, and labeling is again another. So can we? So I will not say much around this. This is a national action plan for transmitting basic elimination through replace, where technical working is performed. And Ministry of National Health Services Regulation Coordination is the chair on it, but there are this is multi-sectoral and representation from various government as well as UN and NGOs and other organizations are there. And through consultations, can you please move there? Through consultation, this national action plan was formulated. It is in final draft phase, but there is one important sort of study that we are waiting on assessments, where we are receiving challenges from the industry. Because of this, this is not being finally endorsed, but hopefully this will be very soon endorsed. And these are harmonized mandatory limits for trans fatty acids to less than 1% of total fats. Extended phase ban on vanaspati ghee, which is partially hydrogenated oil, and the most dangerous to our health, one of the most dangerous to our health. Next slide, please. Harmonized mandatory nutrition labeling as well as build awareness about trans fatty acids among policymakers, producers, suppliers, and retailers. Next slide, please. Then engage electronic, print, and social media for TFA elimination. Undertake survey to assess TFA intake in population. This is the second last slide. So strengthen TFA assessment capacity of food authorities. Strengthen the monitoring and enforcement capacity of food authorities. There are certain outputs, main responsibilities, and stakeholders that has been given there. So next slide, please. And undertake multi-stakeholder research on healthy replacements and promotion of replacement fats and oils. Thank you so much. And this is a slide where there was sort of advocacy the parliamentarians and media, where around 19 parliamentarians they participated in that. Thank you.
Thank you, Dr. Nuri from WHO. Thank you very much for such a nice presentation. My next speaker is Malik Imran Ahmed, country head for campaign for tobacco-free kids in Pakistan. Malik sir, are you ready? Okay. My next speaker is Dr. Sabah Amjad, CEO, Heart Profile. Dr. Sabah Amjad. Thank you.
Thank you, Kuman sir. Honorable Chair, ladies and gentlemen, Assalamu alaikum. I've been asked today to reflect on the role of civil society in advocating for policy change. And I'll be talking on our recent policy engagement and advocacy for trans fat elimination in Pakistan. Next slide, please. Let me quickly walk you through our organization, background, and our niche area. Heartfile and NGO think tank was formed back in 1998 by Dr. Sania Nishtar, who I believe needs no introduction. Our domain of work was on NCDs and in health systems. And our work included both analytical and operational in space of NCDs, health system strengthening, and health governance. In case you are wondering why the name Heartfile, this is because when we started initially, we were only focusing our work in CVDs, and later we expanded our ambit of work to all NCDs. Next, please. This slide echoes what every speaker has been saying. The burden of NCD is the burden of NCD is status. And the statistics say it all. CBDs as Brigadier Saab also mentioned, are responsible for 29% of NCD-related mortalities globally. And on top of that, Pakistan is the second highest per capita TFA intake user in Amro region after Egypt. This slide, as Dr. Noreen rightly pointed out, the culprits in the TFA in our diet. Next slide. It is pertinent to mention that the problem is mainly local. If you can see, the industries responsible for TFA are edible oil industry, the dairy industry, the bakery sector, they are all producing TFA locally. We can see that 98% of trans fat sources are locally produced. And while Pakistan imports a major portion of edible oil, needs the production of partially hydrogenated oil, that is the Banaspati ghee, takes place domestically. The evidence as shared by Noreen is there, global evidence. Different countries, Denmark started in 2000, back in 2003, regulating TFA in diet. There are different approaches. I won't go into the detail, but we at Heartfire, in collaboration with Ministry and WHO, conducted a situational analysis on Pakistan, in context to Pakistan, the TFA. The hard copies are also there if you want for you to take. Next slide, please. How did we approach the subject? As an CSO, we leveraged our policy relationship with Ministry of Health, with WHO, and we brought together the policy process, and we brought provincial and federal stakeholders together. We held in collaboration with WHO and Ministry different workshops to share the evidence that we generated, and we advocated for policy change. First consultation you can see was back in March 2019. Then we had a dissemination workshop in July 2019. Then we had again a workshop in August 2019. The National Action Plan, which the details Noreen has given, was we led the process of, as a civil society, we were there to help government and provide technical support to government to develop this National Action Plan. The second consultation, there were two consultations held on TFA. We were constantly doing as a civil society media and social media engagement. We have formed a documentary, which I'll be sharing later. It's a short documentary. We published op-eds and we had other publications also. While we were doing it, there was a key shift. In January 2020, the CCI decision came, and then the standardization was given to most PSQCA. So our policy direction of advocacy also shifted. Next slide, please. All along the 3 years that we are working for TFA elimination, we have the accomplishments are that the TFA advisory group has been formed, which includes Ministry and WHO and other stakeholders. Also the regulatory changes, you can see that all the provinces other than Balochistan were able to reduce the amount of TFA in the food chain. The details are there. Punjab, Balochistan didn't do anything, but Sindh and KP were there. And also the National Action Plan, we were able to formulate and then have consultations on it as well. Next slide, please. The main challenges we faced as a CSO and other was initially the problem of fragmented regulatory system, which now has been resolved because all provinces had a varying standards and labeling regimes. There was weak enforcement capacity, especially in Balochistan and Sindh. The Banaspati industry started lobbying, as they do in tobacco industry as well. And what they did was that they were able the Punjab government had planned that they will phase out Banaspati by June 20, but they were able to take the petition to court, and that was stalled in July 2020. And now because they said that no longer the provincial department can bring about the change. So since centralization of standards are there, the challenge now with us is to capture at a federal level. Also, the pandemic situation shows that it is difficult to bring about the stricter regulations for food and its enforcement. What we plan to do is to support efforts for enactment of TFA limits as WHO is recommending. We will be working for implementation of the National Action Plan for TFA elimination. We will be generating fresh evidence in collaboration with WHO and writing a report on fresh evidence to rebut the arguments raised by industry. We will also be working on harmonizing the food standards. We will continue with our communication efforts, and we will support other partners and stakeholders in working on technologies to shift the TFA-free products. I'll close my presentation by showing a documentary that we have made working, showing the problem of TFA, the solution to it, and a roadmap to reform as well. It is available on our website, Art Files. We have made a Urdu version, abridged version also for it to reach greater audience. Thank you.
The COVID-19 pandemic has revealed a great deal about our society's problems, including gaps in our economic and health systems. In the choice of its victims, the virus has also revealed another health crisis, that of non-communicable diseases, NCDs. People affected by major non-communicable diseases are far more vulnerable to becoming severely ill with or dying from the virus. NCDs like heart disease, diabetes, and hypertension are among the major causes of morbidity and mortality in the country and account for about 58% of total deaths. A major reason behind this is unhealthy diets. There is an increasingly low consumption of fruits and vegetables in Pakistan amid high consumption of salt, sugar, and unhealthy processed food products. Another severe nutritional challenge in Pakistan relates to dangerously high consumption of industrially produced trans fatty acids, ITFA, a harmful fat found in processed banaspati ghee, margarine, and some cooking oils that greatly increases the risk of cardiovascular diseases, including hypertension and coronary heart disease. About 80% of edible oil products containing high amounts of ITFA are produced locally by partial hydrogenation of vegetable oil. They are typically found in fried products commonly seen in street food and small eateries, bakery items such as pastries and cakes, packaged snacks, biscuits and crisps, popcorn, especially the microwave variety, industrially produced bread products, processed food in supermarkets, and especially in local food items cooked and fried in banaspati ghee. During the past few decades, these ITFA-rich oils have been found to have a causative relationship with coronary heart disease. They are now known to increase levels of dangerous LDL cholesterol and decrease levels of healthy HDL cholesterol in blood. Globally, increased ITFA intake is estimated to be responsible for more than 260,000 deaths per year, and Pakistan is one of the countries most affected, with an estimated 11,000 deaths annually resulting directly from industrially produced TFA consumption. With the issues now well known, countries around the world are taking steps to eliminate ITFA from their food systems. In order to reduce death and disease brought about by widespread consumption of industrially produced DFAs, especially in a country like Pakistan, all stakeholders must come together in action. The government, by means of regulation and enforcement, can play a vital role in this. One of the ways is to impose a statutory limit to the amount of industrially produced DFA in all fats, oils, and food to less than 2 grams per 100 grams, as recommended by the World Health Organization. Another policy approach recommended by the World Health Organization is a complete ban on partial hydrogenation of vegetable oils, which in turn results in elimination of industrially produced DFAs from the food value chain to a great extent. The amount of DFA in any commercially available food item should be printed on packaging and verifiable by the authority entrusted with the task. Whereas the industry producing packaged goods may be able to label their products, the same cannot be said for open food businesses like confectioneries, small restaurants, bakeries, and fresh fried food products providers. This is where the proprietors need to be made aware of the dangers of selling these products and the benefits of replacing their ITFA-rich oils with healthier options. It should be noted that cost to replace may not be as high as feared by businesses because general awareness amongst their customers could help improve sales if their products are healthier. The consumer community should be made well aware of the dangers that industrially produced DFAs predispose their families to. Heart attacks are never pleasant and can destroy lives in seconds. Life not only of the patient, but also his or her entire family. Simple, healthier choices can avert such disasters. People in general should insist on buying only the products labeled as safe from industrially produced DFAs and totally desist from buying from hawkers and small businesses that refuse to switch to healthier alternatives. We are all responsible in our own way to save lives from being lost in this fight to protect ourselves, our families, and our community from sickness and death brought about by this silent killer. Let us all take a pledge to do whatever is in our power to help reduce the prevalence of industrially produced trans fatty acids in our dietary products for a better future of our generations to come.
Thank you very much, Dr. Savarkar. Such a nice. Now I will request my chief guest, Dr. Mariam Letha, to give the shields to my honorable speakers. First, I will request Dr. Shakia for distribution of shield. Please. Shield. I will request to guest speaker kindly give the shield to the Professor Abdul Hamid Siddiqui. Keynote speaker of this occasion. So next speaker is Khwaja Masood Saab, Dr. Khwaja Masood Saab, please. My next speaker, Munawwar Hussain, country head, Global Health Advocacy Coordinator. My next honorable speaker, Dr. Modi Alam from WHO. Next speaker, Dr. Sama Amjad, CEO, R5. I request Abdul Hamid Siddiqui, Professor Abdul Hamid Siddiqui and Dr. Khwaja Saab to give the shield to the chairman, chief guest.
Last but not the least, I'll request Dr. Khalifa to hand over shield to the moderator. Mr. Guman.
I will request the chief guest, Dr. Mayam Deta, for remarks about the chair. Sir, kindly.
Thank you so much. Really a great discussion. There are so many wonderful, excellent presentations. Some are really fascinating. The Major Brigadier, our cardiologist, has given a keynote speech that are really touching the all areas of NCDs, and all the other speakers have spoken so well about the subject, risk factors, what we should do, and the role of civil society, government, and other stakeholders. Let me say why we have selected this topic in series. Now, during our lifetime, we have seen transitions. We have seen witness and subjected to epidemiological transition, demographic transition, and lifestyle transition. And then, of course, we have seen the urbanization and globalization. Now, as a result of all these factors, we have seen another disease group was coming up. We call it non-communicable diseases. The heart disease, the cancers, obstructive airway disease, and diabetes. And we have observed that there are a few risk factors which really cause these diseases. One is smoking, then of course unhealthy diet, then physical inactivity, and then of course it's not a big issue to Pakistan, the alcohol. So tobacco, alcohol, unhealthy diet, and physical inactivity. So three risk factors we see here. And WHO was talking about 4x4, 4 risk factors for 4 diseases. Now it is changed because now we do air pollution also has some major risk factor for heart disease and many other cancers and all also. So therefore now we are talking about 5 risk factors and 5 diseases including mental health. Now looking at risk factors, now we call these are modifiable risk factors because you can change, you can stop smoking, you can have a healthy diet, you can engage in physical activity. So there are, if you engage in risk factors, then of course you develop what is called metabolic risk factors. That's increased blood pressure, increased blood sugar, then of course increased lipid and obesity, which lead to diseases. Now our today engagement is basically on dietary risk factors. And if you look at what are the dietary risk factors, there are a few. One is salt. I think we have not touched upon salt. Salt is we call white poison. Even more than sugar, salt causes increased blood pressure. And blood pressure is the main risk factor today. And my left hand side we have the cardiologist. He will witness is the main cause for many heart disease and strokes. So that's one. Then the sugar, and then trans fatty acid. So all these things are very, very important, and for which of course there are new interventions we have tried about. Now different countries have tried different interventions. Now Denmark is quoted here. Latin American countries are being quoted here. Some countries from Eastern Mediterranean region is quoted here. So through regulation, through taxation, through awareness, through reformulation, we can address these risk factors. So therefore, I think evidence is there globally, evidence is there locally as well. So it is the time for us to get together and implement it. That's what we should do as civil society, as partners, as international agencies, as government. I think there are a lot of initiatives taken, Trans-Pacific. I think we need to go for the registration, regulation now. Some provinces have already legislation, but we have to change it. Some other provinces, we don't have it, we have to go for that. Then taxation has been discussed for tobacco. SSP taxation has been discussed here. So we need to really move forward on that. I have my personal experience about front of pack labeling or what we call traffic light system. I was involved personally to bring traffic light system for sugar. We have the same way. If sugar content is more than 14 grams per 100 ml, we said it is red. 2 to 14 is amber color. Less than 2 is green color. So that's the traffic light system. The moment we embark upon this took long time. It's not an easy battle. You know the industry influence. You know the influence from different partners. But finally, we were able to implement it and start to reduce the sugar consumption. Start to reduce and the industry start to reformulate. Now, after some time, some beverages which were in red immediately transformed to amber. Now we are having the same thing for fat as well and salt as well. So if you look at the consumer right perspective, consumers who consume this food should aware what we consume. So I think now evidence is there, enough studies have been done. So therefore it's time for the implementation. I think as the scientific professionals who are engaged in research, creation evidence, I think we need to engage in awareness also. And people take and consume this without knowing much. Tobacco is straightforward. But unhealthy diet is not that. People don't know much. So I think we need to get involved in this. So again, if you go by, we have NCDs. NCDs are killing 41 million people a year. Annually 41 million people. Out of which 17.9 million people die due to heart diseases, the cardiovascular diseases. Then we have cancers. It was predicted by 2030, number of deaths due to cancers will be overtaken the number of deaths due to heart diseases. This is how things are changing. So that's due to again diet. Diet really affect the cardiovascular diseases and then diabetes and then of course cancer. So 3 diseases we can prevent if you have a healthy diet. So therefore it's very important. Taxation, regulation, awareness and focus on consumer right and reformulation. I think this is what we need to move forward. I'm really delighted to see the wonderful presentation made and all the enthusiastic crowd who are watching all these presentations. And thank you so much for Health Service Academy to invite us. Thank you so much. I am sure that Pakistan future is bright with all these interventions. Thank you.
The chief guest, their valuable time. I want to thanks my honorable speakers and audience was very good time. Thank you very much. I think we have room for with the chief guest.
चलें किसके साथ आए अच्छा फिर खैर मैं मरीन को यही कह रहा हूँ
These cameras are
सही है थोड़ा सा मोबाइल
Thank you very much.
Thank you so much.
Thank you very much.
हाँ जी रात जी रात